I'm going to get going on the presentation. I just want to say thank you, everybody, for having me here at the San Diego Spine Foundation. I am Chris Sullivan. I'm one of the Navy residents here rotating here, trying to learn and absorb as much as I can from what is a group of experts here. And so I get the pleasure to lecture on spinal pelvic parameters and sagittal balance. Throughout this talk, you'll probably see several names from this institution on some of the studies that I'll be referencing. So it'll be great. So overall, this is kind of a confusing topic, at least it was, and still is for me as I'm kind of preparing for this talk. And so as I was going through, I know sagittal balance can be a very deforming condition, but as I started to kind of go through it, all I saw were lines all over the place on all these x-rays, trying to understand everything, which led to me just being very confused of how to sort of evaluate and what really mattered in this condition. And overall, this is somewhat of a newer kind of concept in spine surgery. Over the last 20 years, it's really been a very interesting topic in orthopedic and neurosurgery literature. Significant increase in interest, as well as a very increased publication bias. You can see sort of this graph, a very significant increase over the last 10 years, 20 years of articles that discuss spinal pelvic parameters and sagittal balance, whereas previously it was not as big of a topic and not something that was really discussed all that much. So just a little bit of background. We'll start all the way back in history. Humans evolved from great apes, which historically have walked sort of on all fours, and in those primates, their lumbar spine have pretty limited pelvic tilt and sacral slope, with almost no lumbar lower dorsas to accommodate for that gait. But as humans evolved, they progressively developed more and more sacral slope, more and more pelvic tilt to allow for that bipedalism, which was a significant advantage for humans, being able to have a greater field of view for running and frees up to the extremities for use. So the spine accommodated that bipedalism by becoming more and more upright. But it does have some evolutionary consequences. Epidemiology studies have shown that adult spinal deformity is very prevalent. Over 60% of elderly adults have some sort of spinal deformity, with sagittal plane deformities, in about at least 40% of elderly adults. And as they sort of talk about, this quote has come up several times, that life is a kyphosing event, where we've evolved to get this sort of upright spine, and over time, as we age, we slowly become more and more kyphotic and almost regress backwards. So what is the problem with adult spinal deformity with sagittal balance? Back several decades ago, there was the discussion about the cone of economy, or the conus of economy, is this middle image, which describes sort of the efficiency of the muscular balance in terms of maintaining your balance in the center of your body. As more and more deformities come into play, and you start to vary outside of that minimal cone of economy, there's increased muscle activation and a significant increase in energy expenditure, which eventually leads to pain and disability. As people's deformity gets worse and worse, they start to expend more energy. There's several compensatory mechanisms that help combat that. You can have hyperextension at adjacent levels. You can have flattening of or a change in the thoracic kyphosis to help adjust. You can have significant pelvic retroversion or change in your pelvic tilt, as well as flexion of the knees, and those all are compensating measures to keep your head over the top of your sacrum and to maintain your balance within that cone of economy to decrease the muscular expenditure. Because what is the issue with this, and what do patients really complain about when they start to run into these problems? The main thing is pain. They'll have significant pain when doing any kind of activities, as well as significant fatigue. Many patients will talk about a very limited sort of walking tolerance where they can get up and go, but after a certain time period, 10 blocks, 5 blocks, 1 block, 10 minutes, etc., that their pain becomes significantly worse. They can't necessarily tolerate it. In the picture on the right of an elderly person using a walker, it's a significant aid to them as they sort of can lean forward onto that walker, which can relieve some of that pressure off the musculature of the spine that's fighting to kind of keep her directly upright, and that can certainly offload that energy expenditure and increase the walking tolerance, which is often what you see. In addition, there's a significant cosmetic part of the deformity, which I don't think can be underestimated for a lot of people, and ultimately lead to significant disability for people with this disorder. How disabling is this? Well, the answer in short is very disabling. So this was a 2016 study which showed the health impact of adult spinal deformity. And what it did was it compared SF-36 scores with several other major medical comorbidities. And really, adult spinal deformity is significant compared to a healthy population, and it's generally on par with chronic lung disease and cardiac disease in terms of limiting people's lifestyles and causing significant disability. Correlating with that is a study by Glassman et al. In 2005, which is sort of at the beginning of that inflection point in terms of interest in sagittal balance. What this did was it analyzed self-reported scores as well as radiographic SVA, so their overall sagittal balance. And what it did was it demonstrated that severity of symptoms related to their adult spinal deformity increased linearly with the increase in sagittal deformity with their SVA. And then this study in 2013, which was kind of interesting, did a retrospective analysis of 85 patients with a coronal plane imbalance. But overall, of those 85 patients, 62 had a combined coronal and sagittal imbalance. What they found was that correction of the sagittal imbalance was actually the strongest predictor of improved outcomes. And those who had coronal-only deformities and had improvement in their coronal plane didn't necessarily show, was not necessarily as predictive of clinical improvement. So overall, adult spinal deformities and sagittal plane deformities are common, and they cause significant disability. And the amount of sagittal imbalance correlates very directly with that disability. And so this is important to get right. Overall, meat and potatoes of the talk, spinal pelvic parameters. Just some basic definitions. The sacral slope is on C in this diagram. It's the angle of the sacral plateau to the horizon. The pelvic tilt is B, which is the angle from the sacral midpoint to the center of the femoral heads, and then to the vertical axis. So B and C, the sacral slope and pelvic tilt, are variable. So it depends on the position of the pelvis, as the sacrum can sort of rotate around the femoral heads, depending on the position that the patient can put their pelvis in, whether it's retroverted or anteverted. The pelvic incidence, which is A, that's a combination of sacral slope and pelvic tilt. This is a constant parameter. So this is sort of a description of their pelvis. Small pelvic incidence represents a relatively small and narrow pelvis versus a large pelvic incidence represents a generally wide pelvis or a larger pelvis. So that's a more of a descriptor of the actual patient's anatomy, not necessarily position dependent of the pelvis. Lumbar lordosis represents the Cobb angle between L1 and S1. Alternately, it can be between S1 and the inflection point between lordosis and thoracic kyphosis. That's a relatively simple measure. And then of note, you can also measure segmental lordosis between any of the levels. L4 to S1 is one that is often looked at for segmental, and that is usually 0.66 of the overall lumbar lordosis, which is to say that about 2/3 of a patient's lumbar lordosis come from those two segments between L4, L5, and L5, S1. So that is a very important place in terms of getting that lordosis correct. Some decades ago, Dr. Rusley described 4 phenotypes of this spinal pelvic anatomy, with generally increasing sacral slope throughout the 4 different types. Main takeaway that I think from this is that as sacral slope as pelvic tilt sort of increases, the lumbar lordosis as a compensatory mechanism will increase as well. And what that often does is the apex of the lumbar lordosis can change significantly depending on the increasing sort of slope. So as you can see in type 1 with a very small pelvic incidence, the apex is really at L4, L5 versus type 4 with an increased pelvic incidence. The apex of that lumbar lordosis is higher in the spine. And that can certainly be something that you should be aware of and sort of take into account as a part of your surgical planning. And a key sort of metric is the pelvic incidence to lumbar lordosis. This is Dr. Rusley had a large database of healthy adults. And he sort of used that database to look at radiographs and to determine the relationship of pelvic incidence to lumbar lordosis, and did several different formulas up at the top. But overall, a simple version is that pelvic incidence generally will equal lumbar lordosis, plus or minus about 9 degrees. And so that's often a sort of a normative value that we're looking at. So those are the general, like some of the spinal pelvic parameters, but overall, you need to look more globally at their sagittal balance. So this was a study in AO Spine in 2017, which correlated this sagittal vertical angle and found that thoracic kyphosis and pelvic tilt also have a very significant role in looking at their overall global sagittal balance, correcting not just that sort of ratio of PI to LL. So other sort of markers of global sagittal imbalance, the SVA, the sagittal vertical axis, C7 plumb line, drop down, and then this measures the distance from that line to the posterior superior sacrum. It's an overall description of the global balance, but this also can be a little bit thrown off depending on a compensatory pelvic tilt. If somebody has significant sagittal imbalance, the compensatory mechanism to sort of rotate the pelvis back may sort of bias that SVA to be smaller than what it really is. So to kind of correct that, you have to monitor to make sure that you're getting a correct SVA. In addition, thoracic kyphosis generally measured between T1 or T4 and T12, with a normal value between 20 and 40. And overall, it should represent about 3/4 of lumbar lordosis. And in addition, some more measures of overall sagittal balance, the T1 spinal pelvic angle, which is aligned from the femoral heads to the center of T1, and then align from the femoral head to this middle of the S1 end plate. In addition, you can also measure L1 incidence, or the LPA, which is a line perpendicular to the LPA of L1, and a line connecting to the femoral heads to the midpoint of the sacral end plate, which has also been shown to approximate parallel in terms of importance. Apologies, it sort of skipped over a couple slides. This is just a study in 2009 that showed that the T1 spinal pelvic angle was very important in terms of looking at overall imbalance, and found that that was very closely related to disability scores and patient-reported outcomes out of all of the different spinal pelvic parameters that were measured. And this is one more additional one. This is the cranial sagittal vertical axis, which can be measured from several different points, as you can see on the right, from the sacrum, hip, knee, and ankle. And this was also found to be a very strong predictor of patient-reported outcomes in terms of measuring their overall sagittal imbalance. So what are normalized values? Overall sacral slope should be about 42 degrees plus or minus 8. Pelvic tilt about 13 plus or minus 6. Pelvic incidence 55 plus or minus 10. And then lumbar lordosis in the 40s, depending on male or female, plus or minus 11. Thoracic kyphosis, 40-ish, plus or minus 10. And then an SVA, generally less than 5. And that's sort of a standardized way of kind of looking at it. But comparing what is normal to actually what is looked at as significant disability. So this was a study in 2013 looking at what point patient-reported outcomes represented, an ODI greater than 40, which is severe disability, and patients generally reached that point when they had either a pelvic tilt greater than 22, SVA greater than 47, and then a PILL mismatch greater than 11. So those are sort of important markers for what causes significant disability. And then overall, so that's sort of general parameters that we are looking at and what sort of makes up normal. And then in terms of what we should be trying to accomplish in surgery, this was an overall literature review back in 2010. But the goal is to achieve general spinal harmony, so head over pelvis, with goals of generally a PILL of less than 9, a pelvic tilt generally less than 25, and an SVA of less than 5 centimeters. Those are the initial very general goals, and that was back in 2010. However, can we get a little bit more specific and a little bit better than that? This was an article in 2017 looking at the impact of the PILL, and showed that for every 1 degree increase in the PILL mismatch, there's a 1.4-fold increase in risk of adjacent level disease, and that a PILL greater than 11 demonstrated a positive predictive value of greater than 75% for adjacent level disease. So again, sort of going back to these goals. And overall, as a more specific sort of breakdown of goals to hit, overall, the sort of PILL goal may be generally a little different depending on their pelvic incidence, but this sort of gives a little outline of what we should be looking at in terms of what is sort of normative values for lumbar lordosis. But as we sort of break this down, the alignment thresholds should also account for age. So this was a retrospective analysis of over 770 patients with adult spinal disorder. They're generally stratified by age, and it demonstrated that people tolerate generally increased sagittal plane deformities as they get older, as they sort of say life is a kyphosing event. That's somewhat of a natural sort of compensatory mechanism as people age. And so our operative targets should also account for that age, and we should not treat everybody as the same depending on their age. So based on their disability scores, as you can see, as age kind of goes up on the left, their pelvic tilt significantly increases, their PILL significantly increases, and their SVA generally increases as a norm. So this is sort of what people generally will tolerate. And so age-specific alignment criteria, as you get older, you generally don't need to correct them down as much, is essentially the takeaway. So pelvic tilt, as a younger patient, should aggressively try to correct that down to about 11 degrees, and the PILL down to -10. But as they get significantly older, you can tolerate significantly more. A significant SVA as you get older, to greater than 5 centimeters as the age of 65. And does that legitimately help? This was a study at 2017, which compared age stratified, basically less than 40 to 65, and greater than 65, and compared 1 year postoperative alignments and offsets. And basically what it shows is that there's an increased chance of proximal junctional kyphosis in the older subgroups, which was generally due to an overcorrection of those spinal pelvic parameters. That just kind of that sort of general goal. This is also important, not just in deformity surgery, but for lots of different surgeries. So the patients who have a significant neurologic component to their symptoms, people who have lumbar stenosis, we should also take into account their deformity. This was a retrospective analysis of 679 patients with lumbar stenosis and grade 1 spondylolisthesis. These patients basically underwent decompression alone for that, or decompression infusion. And each group was kind of subdivided into a low or a high PILL mismatch, which was generally used to represent whether or not they had a sagittal malalignment. And overall, those who had a sagittal malalignment had better outcomes and lower revision rates when they had a decompression infusion, versus those who had who did not have a sagittal malalignment had a better outcomes in terms of patient-reported outcomes and a lower revision rate when they just did a decompression alone and didn't include the higher morbidity fusion aspect into that surgery. So alignment plays a role in lumbar stenosis as well. And then overall, how good are we at achieving all of these goals they were setting out in terms of our sagittal alignment? This is a 2013 study, which had 266 patients who had adult spinal deformity, and compared what the surgeon had as their preoperative goals, and then aligned that with their postoperative radiographs. And overall, there was a failure to achieve the preoperative correction goals in about 25 to 30% for each sort of spinal pelvic parameter. And overall, there was a general failure to correct all three in 62.8% of patients. So generally, there's a tendency to undercorrect the PILL and the SVA, with a tendency to increase thoracic kyphosis. So overall, we're still working on improving this and getting better at meeting our goals. But overall, in conclusion with this sort of literature review, sagittal deformity is common and is a significant cause of morbidity. Very generalized goals should be a PIL less than 10, SVA less than 5, so like 4 or less. Pelvic tilts generally less than 25 or less than 20. That age matters, and so we should focus on not overcorrecting the elderly population, and to keep that in mind, sort of age specify your goals, and to be aware of these spinal pelvic parameters and sagittal imbalance, even in non-deformity cases. I didn't necessarily dive into a lot of the specific surgical techniques to how to achieve these goals, but there are numerous and varied sort of thoughts on how to do that, and how proximal and how distal to go. But overall, this is a sort of broad strokes review of those goals, and these are my references. And sort of with that, I'll open up the floor to questions, comments, concerns.
Oh, well done, Chris. And I presume you learned a lot. It's a deep dive.
I did. So it was a good topic, and several names keep popping up in the literature reviews from here. So
I'd be a little bit careful with the discussion about age. I'm not sure we understand that fully, other than what you said, the overcorrection issue. You know, there has been a period of time that we thought that correcting the elderly should be done in a way that was age specific or age sensitive. And I'm not sure that's true. The data is not terribly compelling that that's true. It is probably true, to your conclusion point, that overcorrection is more devastating in an older patient, particularly when bone's not very good, because they have less capability of compensating, probably more sarcopenia, just less capability of handling a misfire on their alignment, and more likely to suffer PJK and PJF. So I think your conclusion's right. I just want to make sure that you understand that the whole concept of age appropriate alignment is coming into some significant question that we probably are not quite as on target as we think we had historically been with that. And interestingly, I mean, alignment has to consider a bunch of different things, including balance and vision and lower extremity dysfunction. And, you know, it's not so simple as the spine should be this. As we get older, we start using other means of guiding ourselves safely that changes the needs of the spine, or from the spine, in a sometimes pretty dramatic way. And you have to consider all of those factors and the implications and ripple effects that you create when you start changing the spinal alignment towards something that you otherwise would think is idealized.
Right. It's not just looking at the radiographs and determining what they should be, but taking an actual clinical picture. Obviously very important. Right.
Any other input? Great job. Thank you for
Thanks a lot, Chris. Appreciate it, Chris.
For sure. Thank you, everybody, very much for your attention and for teaching me as much as you can. Thank you very much, everybody.